Okay, so we've talked to you about where the Research Associates program started and came from, a little history behind it. Hopefully got you excited about being a research associate. We've talked to you about tobacco cessation and why you should be excited about the idea that you're going to be helping people to stop smoking, to stop using tobacco. And now we're going to go and talk specifically about the research that's involved in the study that you're going to be doing for the spring semester, summer semester, and fall semester of 2012. And so this is about tobacco cessation in the emergency department utilizing research associates. We started this off by doing a pilot study, and this is a progression of how this body of research can be done. Basically, you do a pilot study to start at a particular hospital. We did it at St. Vincent's here in Bridgeport, Connecticut. Followed by, if the study looks pretty good, you follow up by a validation study in a couple of other hospitals. That validation study was completed in 2011, right? We just finished it in December. And the next, if things look pretty good, the next you move is to what you all are going to be involved with, and that is a multi-center national study that sees if this is something which can be generalizable to the population. Can this be done everywhere? And in a way, looking at this, should this be done everywhere? Should we have research associates in the emergency department helping people to stop smoking by asking them questions about their tobacco history, and if it's positive, asking them if they want a quitline referral? So we have to see if, while it sounds like a great idea, we have to find out whether it's really effective or not. So we started this with a pilot study. And in the pilot study, we used a scripted format, and that's absolutely key. We run all of our studies in the tobacco cessation, from pilot validation and now the multi-center national study, are run off the scripted formats. It's done that way because A, it's research, right? In research, if you do the same thing the same way every time, and you get a particular set of results, then hopefully if you do it, another person comes and says, wow, we ought to do it that way too. They try it, their results would be similar. So it's generalizable to the population. The second reason is that right now, research associates, right, pre-health professional school, before going on to professional school, are able to do this kind of research based on the fact that we help you to say the right thing. You don't have to worry about what to say. We tell you what to say. Everything that's in italics, as you're going to hear in the red cap on showing you about red cap. Everything that's in italics, we want you to say word for word. And we jump up and down, and scream about that. That's true. Because A, it's research. B, you don't have any of those initials at the end of your name, right? You get MD or DO or PA or NP or PT or anything else at the end of your name. You can say it any way you want. But right now, we need you to do this exactly as we ask. How do we get 500 plus college students around the United States to all do something the same way? We have it on a computer. We have it specifically defined as to how we want you to do this, and we want you to follow this exactly, word for word. Okay? Does it mean there aren't better ways to do it? Possibly. And if you think there's a better way to do it, we absolutely want to hear that. Because the more we hear of those things, the more we can change it. There potentially is a better way of doing it. Okay? We've been using this particular model for about 4 years now, and we've defined and refined and gone over this and sliced it and diced it in lots of different ways. And the reason we've been able to do that is because research associates have come and told us, hey, how about doing it this way? We'd love to hear that. But what we don't want to have happen is the research associates go off on their own and change things, right? Just on their own. We don't want you to do that. We want you to follow the instructions that your chief research associates are going to go over with you. So you do the same thing in a scripted format, the same way every time. The same way on the East Coast and the Central Time Zone on the Pacific Coast, in small hospitals and large academic centers, with lots of RAs or with only a few RAs. It doesn't matter. What matters is that RAs are committed to doing the same thing the same way every time, because This is research. So the RAs approached as many emergency department patients and their visitors as possible on their weekly 4-hour shifts. Okay? It's real simple. Your job is what you probably want to do anyway, and that is see as many sick people and their families or friends or visitors as you possibly can during your time. They obtained a verbal assent or a written informed consent, took a detailed tobacco history, just like a doctor does. Right? Just actually more detailed than you'll ever do, except when you're a third-year medical student. Third-year medical student, you take the most detailed histories you'll ever take. But except for that, you'll do more detail about their tobacco use than any other time in your career. And then, if it's appropriate, for all those who smoke for more than 30 days at any time in their lives, you're going to offer them a referral to the Connecticut quit line here in Connecticut. But since there's a quit line in every state, right, you will offer them to the quit line appropriate for the state that you're in. So what do we find? This actually worked. Well, in 21 weeks, we had 63 RAs who approached 4,613 potential participants. Just the idea that in the emergency department you could actually approach that many potential participants is a remarkable piece in and of itself. 88% were eligible, that is, they didn't have exclusion criteria. And RAs were were able to enroll 3,125 participants in the study, which is about 78% of those who were eligible. What's important about that is that there's going to be, 22% who are going to say no, or who said no. That's okay. They don't have to be in the study, right? You've approached them, you've asked them. We know that there's some people who are just going to say, this isn't the time I want to talk about that. Perfectly fine. Not a problem. We just need to know who those patients and visitors are, so that's part of the study itself. Okay, as we'll go over with you when we talk about REDCap, about how we enroll people in the study. If they had a smoking history that was positive, that is, they had smoked at any time in their lives for more than 30 days, we offer them a quit line referral. Now some people say, well, okay, wait a second now. Somebody says, well, I haven't smoked in 20 years. How come I'm being offered a quit line referral? Well, a couple of ideas on that. One, screening is throwing out a big net. Bringing in as much as you possibly can, making sure you don't miss anybody who potentially could benefit with a quit line referral. And if it turns out that they say no because they've already quit, that's okay. No harm, no foul. What is, and yet, since tobacco or nicotine is such an addictive agent, it really is a lifelong addiction by definition. And you can talk to people who stopped smoking for 20 or 30 years, and if you said to them, look, you know what? No harm, no foul. No health consequences, nothing else. Would you start smoking again today? And I'll tell you in a heartbeat. It was wonderful. I loved it. But it's going to kill me, and I know that I don't want to do that. Or it's going to harm other people in my family. I don't want to do that. Whatever their reason, they've stopped, but they sure would like to start again. And so with a lifelong addiction, we were actually surprised at the number of people who had stopped for a large number of years who still wanted the reinforcement that a quit line could offer to them in terms of keeping them from starting smoking again. What we found is 54% used tobacco at some time in their life. What was important about that was that's about the same percentage of people, the demographics from the government who look at these in statistical kinds of ways. So that's about the same percentage of people in Connecticut that smoke cigarettes at some time in their life. So the idea that the emergency department, half the U.S. population goes to the emergency department every year, is representative of smokers in general, it seems to be borne out at least in part by that number. And 22% had smoked within the preceding 30 days, used tobacco within the preceding 30 days. And that's, again, about what the statistics would tell us is like what it's like in the state of Connecticut, and that's our real target area. If you had smoked at any time for 30 days, any time in your life, almost 1 in 5 times, about 18%, would accept the referral to the quit line. If you smoke within 30 days, active smokers, almost 4 in 10 accepted a quit line referral, 38%. We were amazed at that. We were like, wow, this is something to be really good. When we look overall at how many people were referred to the quit line in the entire state of Connecticut during that time period, about 50% of those who were referred came from the St. Vincent's Emergency Department. Didn't come from clinics, didn't come from doctors' offices, didn't come from other hospitals, came from the St. Vincent's Emergency Department. One emergency department in the entire state had about 50% of all the quit line referrals. When we looked at those numbers, we were really excited. We were like, wow, this could be really, really good. So the next step is to do a validation study, right? Maybe it's just St. Vincent's, right? Maybe it's just because we have people here who are really dedicated to this whole concept, this whole issue. Can this be done in other places? Well, we did. We did the same study design, except it was all verbal consent, and we used what's called REDCap. Now, Brian King, one of our NARAP Chief Research Associates, is going to go all over REDCap with you, because that's how you're going to, the program you're going to use to enroll participants in the study. However, briefly, it is a way that data can be collected at different institutions around the country, or indeed around the world. REDCap has, I think now about 125 to 150, I think it is, institutions that use it, and use it to do multi-center studies throughout the world. And basically enroll data, put the data in Bridgeport in Connecticut, and in Pullman, Washington, and in Texas, and in Philadelphia, and every place else in our study, put in at the same time, all goes to the same place, put into the same database, and can be analyzed literally in seconds. It's pretty cool. St. Vincent's, part of the study we enrolled, we also had Hartford Hospital and Lawrence Memorial. Now, St. Vincent's, a inner city and suburban hospital in one of the largest cities in Connecticut, but basically a community hospital with some teaching parts to it as well, teaching programs. Now, the major teaching affiliate now of Quinnipiac University's New School of Medicine. Hartford Hospital, the major teaching affiliate for the University of Connecticut, a large tertiary care center in Hartford, Connecticut. And then Lawrence Memorial, a smaller community hospital, no research, no academics, no residencies. They take care of patients. They take care of them really, really well. That's where their focus is, but none of the other things that happen in a major medical center. So a cross-section not only of the state of Connecticut, but also of the kinds of hospitals that we thought could be part of an effort such as the Research Associates in Tobacco Cessation. We did beta testing in the fall semester of 2010, and then in the spring, summer, and fall semesters of 2011, we did the validation study. You know, was it just St. Vincent's, or could this be done in other places? In 30 weeks, we enrolled about 7,500 participants. Again, the numbers just are boggling, mind-boggling. And when we did this study, again, this study was basically finished in December, and we're still analyzing the data. But the big numbers are that we had about the same percentage of participants in the study who were smokers as we had in the pilot study. And in general, in pilot studies, when the pilot study is when you're going to have your best numbers. And then you go to a validation study, and things are expected to get watered down a little bit. You're not expected to be as successful in a validation study, but it shouldn't be off by too much. What happened in the validation study was that we found that if the big number, if you smoked for within the last 30 days, or an active smoker actively using tobacco, then more than 50% of the time, you would accept the referral to the Connecticut quit line. Okay, more than half the time. That's just staggering. If we really want to make an impact on tobacco cessation around the country, what the validation study says is it is possible, to be proven, but it is possible that we can do this in this kind of a model, in the kind of a model you're going to be involved with. So what's the next step? Next step is you guys. Right? The next step is an army of just cadre, a huge number of research associates, of college students who see the value to their career of working with patients directly to discern, qualify, and personally develop, as we always say, that when you are there as a cadre of people who can make this kind of a thing happen, and it can't happen without you. In this national study, developed through the National Alliance of Research Associate Programs, NARAP, 15 hospitals around the country, different kinds of hospitals, just like we did in the validation study. Academic centers, small community hospitals, East Coast, Central, West Coast, different kinds of areas, inner city, suburban, urban, rural, as diverse as we can possibly get. It looks like, if we have the estimates about right, that in the 30 weeks, the three 10-week semesters of 2012, starting with y'all in the spring, followed by another group in the summer, and in the fall again, hopefully many of you participating in all three semesters, we will have a study that in 30 weeks will enroll 70,000 participants. This could be the largest prospective interventional clinical study that's ever been done in such a short time frame. And I want you all to be tremendously excited about that. Okay? You have a chance to be at something that is really big, that's really different, that can actually change how we do healthcare in the United States. How we can utilize the three numbers. Half the U.S. population goes to an emergency department every year. They're there for 4 hours on average. And there's over 500,000 college students who think they want to go to medical school or other health professional school. We can bring those, this is an example of what could be accomplished if we can bring those three numbers together, done in a research format. And not for nothing, I think it's really important that you all have this in front of you in a way that you see that this is to your self-interest, okay? How neat would it be to go on a medical school interview, right? And some doctor like me with gray hair is sitting back at a desk and saying, so, you know, Mr. Thomas, why do you think you know you want to be a doctor? So, well, Dr. Thomas, I was a research associate in and enrolled 100 to 150 patients every semester in the largest prospective interventional clinical study that's ever been done. I think I know what it's like to work with patients and their families. Versus, I was in a lab and I killed a bunch of rats. Those are two different kinds of interviews. We think that you all are going to benefit from being part of the former. Adding in that the latter is not, you know, it's not bad. I just think that if you want to be a people doctor, that it's real important that you work with people. You work with patients. You'll find out whether this is really for you. You'll help your qualification getting into school, and you'll develop your patient skills in ways that you can't do in very many other kinds of programs other than research associates. So, okay, I'm done for today. You're going to have, Ryan King is going to come talk to you about the specifics of REDCap and how to enroll people into the study. Our chief research associates have put together a very interesting video that I think is going to help you to see how you can be a research associate in the most effective way. And I'm done. I will be on the phones along with our NARAP chiefs to answer any of your questions. Again, after each of these sessions, each of these sections, there's going to be a time for you to have a break, to come up with your questions all written down, call them into us, and we will address them specifically to your institution. And if they're general enough, we will put them into basically onto the video of how this is presented nationally down the road. So again, thank you very much. We look forward to having you working with us.